Welcome to the Assembly Committee on Health and Human Services. Would the Secretary please take the roll?
Assemblywoman Gonzalez. Here. Assemblywoman Gorlow. Here. Assemblyman Gray. Here. Assemblyman Hafen. Here. Assemblyman Hibbets. Assemblyman Koenig. Here. Assemblywoman Newby. Here. Assemblyman Wynn. Here. Assemblyman Orentlicher. Assemblywoman Taylor. Assemblywoman Thomas. Chair Peters.
And I am here. Please mark Assemblywoman Thomas and Assemblyman Orentlicher present when they arrive. Excuse me. Well, so we have mostly work session agenda today. I'm going to go over a couple of housekeeping items in case anybody has forgotten over the week, because we're obviously spending not enough time in this building. Please silence all of your electronic devices, especially cell phones and laptops, so we're not interrupting folks as they're speaking. Members of the public may provide testimony in a variety of ways, all of which are listed on the agenda. You may also submit public comment in writing. In addition to or in lieu of testifying, written public comment may be submitted before, during, or up to 24 hours after the meeting's adjournment. If you wish to testify in person, please sign in by the door and leave a business card so we have an accurate record of your name and contact information. If you do not testify, you may also want to sign in there so that we have a record of those who are interested in particular bills and the case that we would like to reach out to you. To ensure an orderly flow of discussion, all comments, questions, and responses must go through me. Also, committee members must be recognized by me before you can speak. Additionally, I ask our presenters on Zoom video call to leave your cameras off and microphones muted until it's your turn to present, or if I direct any questions to you. When testifying in person, please turn the microphone on to speak and off to listen, so that we do not have a reverb and we have a clean recording. With that, we'll move on to our agenda. We are going to start with work session. We have a pretty decent agenda here for work session. Everyone has access to these work session documents. They should be on your desk, and they are also online. And let's see, did I forget anything before we move forward? All right, well, I'm going to ask Mr. Ashton to please begin with Assembly Bill 6. I'm sorry. Oh, brief recess. All right. We will begin. Mr. Ashton, Assembly Bill AB 6.
Thank you, Chair Peters. For the record, Patrick Ashton, Research Division, Legislative Council Bureau. My usual reminder, as nonpartisan staff, I can neither advocate nor oppose any measures before you today. Assembly Bill 6, which was heard on March 29th, requires the Director of the Department of Health and Human Services to annually establish a healthcare cost growth benchmark for the immediately following year in an amount equal to the healthcare cost growth target established by the Governor in the Executive Order 2021-29. The bill's intent is to establish targets for the growth of spending on healthcare for each year and engage pertinent state agencies and relevant stakeholders to develop strategies to meet those targets, and monitor and publish certain reports concerning the growth of healthcare spending. There were no amendments. Chair Peters?
Thank you. Do I have any questions from the committee? Seeing none, I would entertain a motion to do pass Assembly Bill 6. So moved. Thank you. I have a motion from Assemblywoman Gonzalez, a second from Assemblyman Nguyen. Is there any discussion on the motion? Assemblywoman Newby.
Thank you, Madam Chairwoman. I still have concerns on AB 6, but I am going to vote to pass it out of committee and hope that the sides will come together and work something out. I don't think that they've been sufficiently talking so far. Thank you.
Assemblywoman Taylor.
Thank you, Madam Chair, and I'm just going to ditto the remarks of my colleague.
Thank you. Any other discussion? Seeing none, all those in favor, please signify by saying aye. Aye. Any opposed, nay? Please raise your hands. We have nays from Assemblyman Hafen, Koenig, Hibbets, and Gray. The motion passes. And I will assign that to Assemblywoman Gorlow, please. Thank you. We'll move on to Assembly Bill 7. Mr. Ashton.
Thank you, Madam Chair. For the record, Patrick Ashton, Research Division, LCB. Assembly Bill 7 was heard on March 29th, and I will go straight to the amendments that were also discussed during the hearing. So Ms. Bond, Executive Director, Culinary Health Fund, proposes the following amendments. Revise the immunity provisions of a healthcare provider who transmits, accesses, utilizes, discloses, relies upon, or provides to the patient any apparently genuine electronic health record in accordance with the applicable law and regulations. Provides that transmitting, accessing, utilizing, or disclosing an electronic health record is not an unfair trade practice. Authorizes the Director of DHHS to contract with multiple health information exchanges. Removes a requirement that the Director must encourage the use of health information exchanges, and prohibits the Director from requiring any person to use a health information exchange. Requires certain facilities and healthcare providers to maintain, transmit, and exchange health records electronically in a certain manner, which are outlined in item 5A and B on the bill page, and appropriates $3 million to the department from the State General Fund. Thank you, Chair.
Thank you. Are there any questions from the committee? Seeing none, I would entertain a motion to amend and do pass. From Assemblywoman Gonzalez, second from Assemblyman Nguyen. Is there any discussion on the motion? Seeing none, all those in favor, please signify by saying aye. Aye. Any opposed, nay? And please raise your hands. Assemblyman Hafen, Assemblyman Koenig, Assemblyman Hibbets, and Assemblyman Gray are all nays. The motion passes. We will move on to Assembly Bill 11. Oh, thank you. For a statement to you, Assemblyman Nguyen, please. Thank you. All right. Assembly Bill 11.
Thank you, Chair Peters. For the record, Patrick Ashton, Research Division, LCB. For the sake of time, regarding Assembly Bill 11, which was heard on March 29th, I will go straight to the amendments. Chair Peters proposes the following amendments. Revise subsection 1 of section 1 to prohibit any hospital or psychiatric hospital from hiring new physicians, homeopathic physicians, or osteopathic physicians, except as currently authorized by subsection 2 of section 1 of the bill for graduate programs. This prohibition does not apply to a physician or osteopathic physician who is currently employed on the effective date of this bill and does not apply to any state hospital or psychiatric hospital. Number 2. Retain existing provisions in law and a bill that a county hospital or hospital district, a private nonprofit medical school, a nonprofit medical research institution, and a hospital or psychiatric hospital who is participating in certain graduate programs is authorized to employ a physician under certain circumstances. Number 3, require the Joint Interim Standing Committee on Health and Human Services to conduct an interim study concerning the corporate practice of medicine doctrine, which prohibits corporations from practicing medicine or employing a physician to provide professional medical services. The committee may request the drafting of one additional legislative measure for consideration by the regular 2025 legislative session to amend the prohibition set forth in item 1 and related statutes. Number 4, prohibit a hospital from including in a contract for employment or the provision of services any provision that prohibits a provider of healthcare from providing services in another facility or other setting while the provider of healthcare is employed or serving as an independent contractor at the hospital, or after the provider of healthcare ceases employment or service as an independent contractor for the hospital, or, except as otherwise provided in item 5 below, on the work session document, disclosing information concerning the contract for employment or services, wages and hours, harassment, retaliation, assault, or other information relating to working conditions. Number 5, prohibit a hospital from taking action to prevent a provider of healthcare from engaging in any activity described in item 4 or imposing discipline against a provider of healthcare or group practice or otherwise retaliating against a provider of healthcare or group practice because the provider of healthcare or a member of the group practice has engaged in any activity described in item 4. And item 6, provide that items 4 and 5 must not be construed to prohibit a hospital from taking any action necessary to prevent the disclosure of information that is protected by HIPAA or otherwise declared confidential by law or court order. Thank you, Chair.
Thank you, Mr. Ashton. Are there any questions? Seeing none, I would entertain a motion to amend and do pass. Assemblywoman Gonzalez, Assemblyman Nguyen, with the second. Thank you. Is there any discussion on the motion? Assemblywoman Newby.
Thank you, Madam Chairwoman, for indulging me. I really appreciate all the work that you and the folks that are involved in this bill went through to get this amendment, and I think it's fair and balanced and a good piece of legislation, so thank you.
Assemblyman Nguyen.
Thank you, Madam Chair. I want to echo my colleague's sentiment. I was originally were not in support of this, but your work on the amendment and really, especially for section, the number 4 of the amendment, really highlight my main concern, and I want to make sure that our doctors are not being tied to one location and therefore prevent from serving our community the way that they should be. So thank you, Chair, for your work on this.
Thank you, Assemblywoman Taylor.
Thank you, Madam Chair, and once again, I appreciate your work, and I just haven't been able to get through the amendment because I was in the meeting in the afternoon, so I'm going to vote to pass it out of committee, but then we'll reserve my right once I get a chance to dig in and see where we are on this.
Thank you. I can't imagine what anybody was busy with this morning. Any other discussion? Seeing none, all those in favor, please signify by saying aye. Aye. Any opposed, nay? Nay. Please raise your hands. Assemblyman Hafen, Assemblyman Koenig, Assemblyman Hibbets, and Assemblyman Gray are nays. The motion passes, and I would assign that. I'm going to go ahead and take that floor statement. All right, we're going to move on to Assembly Bill 85. Mr. Ashton.
For the record, Patrick Ashton, Research Division, LCB. Assembly Bill 85 was heard on March 3rd. It establishes procedures to fix rates charged by hospitals, independent centers for emergency medical care, and surgical centers for ambulatory patients for goods and services that are reimbursable through Medicare when provided to a patient who is not indigent and not covered by Medicare or Medicaid. The bill also establishes a commission that shall fix rates at Medicare rate levels, pursuing that each healthcare facility is able to cover reasonable costs, earn a fair and reasonable profit, and provide fair and adequate compensation to its employees. The bill requires the division to adopt certain regulations on rate fixing, including regulations establishing civil penalties to be imposed against a healthcare facility that violates provisions governing rate fixing. Amendments. Vice Chair Ornlicker proposes the following conceptual amendments. Number 1, limit the procedures for fixing rates to the public option and group insurance for state officers and employees through PEP. Revise Section 9 by requiring the Commission to set either a single multiplier of Medicare rates for each facility that would apply to all services, or in the case of hospitals, either a single multiplier for all services or one multiplier that would apply to all inpatient services and a second multiplier that would apply to all outpatient services. Require the Commission to review and study the impacts of the rate setting and report them to the Joint Interim Standing Committee on Health and Human Services by June 30th of every even-numbered year, and revise subsection 5 or section 6 to require the governor to appoint at least one member who represents a hospital or the Nevada Hospital Association instead of a healthcare provider practicing in the state. Thank you, Chair.
Thank you, Mr. Ashton. Are there any questions from the committee? Seeing none, I'd entertain a motion to amend and do pass. Thank you, Assemblywoman Gonzalez with a motion and Assemblywoman Thomas with a second. Any discussion on the motion? Seeing none, all those in favor, please signify by saying aye. Aye. Any opposed, nay? Please raise your hands. You guys getting an arm workout today. Assemblyman Hafen, Assemblyman Koenig, Assemblyman Hibbets, and Assemblyman Gray. The motion passes. And I will assign that to Assemblyman Ornlicker. Move on to Assembly Bill 155.
For the record, Patrick Ashton Research Division LCB Assembly Bill 155 was heard on March 17th. It requires certain public and private health plans, including Medicaid, and health plans for state and local government employees to provide coverage for biomarker testing for the diagnosis, treatment, and management and monitoring of a disease or condition when such biomarker testing is supported by medical and scientific evidence. It sets forth certain conditions for requesting and providing such testing and authorizes the Commissioner of Insurance to take certain actions against health insurers who fail to comply with requirements established by the bill. Amendments. Assemblywoman Peters proposes the attached conceptual amendment. In summary, the amendment, and members, I will just summarize the provisions of the amendment that were added after the bill hearing, as outlined in items 7 through 10 on the bill page. So item 7, revise subsection 1 of section 15 by requiring the director of DHHS to pay the non-federal share of expenditures incurred for biomarker testing only when conducted by a qualified provider, as determined by the director, supported by medical and scientific evidence, and deemed medically necessary by a qualified provider. No other cost-effective alternative is available to meet a Medicaid recipient's acute and long-term medical or other healthcare needs other than biomarker testing. Item 8, revise all sections that require public and private health insurers to provide certain coverage for biomarker testing only when conducted by qualified providers, supported by medical and scientific evidence and deemed medically necessary by a qualified provider, and no other cost-effective alternative is available to meet a recipient's acute or long-term medical or other healthcare needs other than biomarker testing. And item 9, clarify that any health insurer is not required to pay more than the lowest rate prescribed by contact between the insurer and the provider conducting biomarker testing, and add certain co-sponsors to the bill. Thank you, Chair.
Thank you, Mr. Ashton. Are there any questions? Assemblyman Nguyen.
Thank you, Madam Chair. I was recently in my office this morning and had really awesome testimony from two constituents in my district. One is a 15-year-old young lady and her mother on how important this is life-saving measure. So if you don't mind, Chair, I would like to add as a co-sponsor of this measure.
Yeah, that would be great. Thank you. Any other questions? At this moment? Sure. Assemblyman Hafen.
Madam Chair, I just wanted to say thank you for working on the amendment. The fiscal note kind of scares me, but I do think this is good policy, and therefore I will be voting yes today to get this out of committee, and I do look forward to trying to reduce that fiscal note in ways and means, and so I do want to say thank you.
Thank you. And a big thank you to the state for sitting down with me to talk about the intent of the bill and work on some language that worked for making sure that we are using those taxpayer dollars adequately. Is there any other question before we move into motion? All right, I would entertain a motion to amend and do pass. Assemblywoman Thomas with the motion and Assemblyman Gray with the second. Is there any discussion on the motion? Seeing none, all those in favor, please signify by saying aye. Aye. Any opposed, nay? Motion passes unanimously with those present. And I'm going to go ahead and take that floor statement. We will move on to Assembly Bill 168. Mr. Ashton.
For the record, Patrick Ashton, Research Division LCB, Assembly Bill 168 was heard on Monday, and I will go straight to the amendments. Assemblywoman Thomas proposes to replace the bill's provisions with the attached conceptual amendment of the work session document. And in summary, the amendment establishes a fetal and infant mortality review program within DHHS to conduct an in-depth review of individual fetal deaths and deaths of infants under 1 year of age, as directed by the Advisory Committee on Minority Health and Equity. And members, the only change to the amendment as presented during the bill hearing on Monday is item 2 in the conceptual amendment. Item 2 was replaced with the following statement of intent. Make conforming changes to Chapter 432B of NRS to clarify the scope and objectives of the fetal and infant mortality review program and child death review teams. The intent is to reflect the flexibility for both the child death review team and the program to review a death when it is within the scope of either entity. For this purpose, such teams and the program may coordinate their respective case reviews and share information in a confidential manner to avoid any duplication of efforts. Further, the intent is to ensure that the program's data and findings are reported to the national database of the National Center for Fatality Review and Prevention and included in the state's annual child death report, and that no case is reported more than once to the database or report. Thank you, Chair.
Thank you, Mr. Ashton. Are there any questions? Seeing none, I would entertain a motion to amend and do pass. So moved. From Assemblywoman Gorlow, a second. From Assemblywoman Taylor. Any discussion on the motion? Seeing none, all those in favor, please signify by saying aye. Aye. Any opposed, nay? Motion passes unanimously with those present. And I will give that floor statement to Assemblywoman Thomas.
Thank you, Chair.
Thank you. And we'll move on to Assembly Bill 179.
For the record, Patrick Ashton, Research Division LCB, Assembly Bill 179 was heard on March 22nd. It establishes the Perinatal Quality Control Collaborative within the Division of Public and Behavioral Health of DHHS to improve maternal and neonatal health outcomes. Assemblywoman Gorlow proposes the following amendments in the attached mock-up of the work session document. In summary, the amendments revise the name to Perinatal Quality Collaborative throughout the bill, revise the membership of the collaborative, revise the collaborative's purposes and ensures they apply to the state, require the collaborative to additionally review and analyze recommendations from certain entities that review maternal, children, infant, and fetus deaths, revise the collaborative's authority to additionally access certain reports and data, but removes its access to certain information from medical facilities and health insurers, and requires the director of DHHS to appoint a clinical director. Thank you, Chair.
Thank you, Mr. Ashton. Are there any questions from the committee? Seeing none, I would entertain a motion to amend and do pass.
So moved.
Thank you, Assemblywoman Thomas. A second from Assemblywoman Gonzalez. Is there any discussion on the motion? Yes, Assemblyman Gray.
Thank you, Madam Chair. I'm going to vote yes to get this out of committee. I do like the idea, but I do have some concerns around midwives and fiscal notes and stuff, so I will vote it out of committee though today.
Thank you. Any other discussion? Seeing none, all those in favor, please signify by saying aye. Aye. Any opposed, nay? Nay. Please raise your hands. Assemblyman Hibbets and Assemblyman Hafen are nays. The motion passes, and I will give that floor statement to Assemblywoman Gorlow, please.
Thank you very much.
Move on to Assembly Bill 188. Mr. Ashton.
For the record, Patrick Ashton, Research Division LCB, Assembly Bill 188 was heard on March 27th. It revises the circumstances under which a physician is authorized to prescribe or recommend and manufacturer is authorized to provide or make available an investigational drug or biological product or device to a patient diagnosed with a life-threatening or severely debilitating disease or condition. There were no amendments. Thank you, Chair.
Thank you. Are there any questions from the committee? Seeing none, I would entertain a motion to do pass. From Assemblyman Gray and a second from Assemblywoman Gonzalez. Any discussion on the motion? Seeing none, all those in favor, please signify by saying aye. Aye. Any opposed, nay. The motion passes unanimously with those present. And I would give that floor statement to Assemblywoman Kasama. Do Assembly Bill 358 next.
For the record, Patrick Ashton, Research Division, LCB. Assembly Bill 358 was heard on April 7th, and it adds the Bureau of Emergency Medical Services to the State Fire Marshal Division, Department of Public Safety, and requires the appointment of a qualified chief. It transfers various authority and duties related to emergency medical services for counties whose population is less than 700,000 from the State Board of Health to the Bureau. The bill requires the director of the department to appoint the Committee on Emergency Medical Services and revises the committee's membership and duties, requiring it to advise the Bureau instead of DPPH. Amendments. Chair Peters proposes to amend this bill by requiring the State Board of Health to review and approve any regulation adopted by the Bureau of Emergency Medical Services of the State Fire Marshal Division pursuant to Chapter 450B of NRS as amended by the provisions of this bill before the regulation is submitted to the Legislative Commission. Thank you, Chair.
Thank you. Are there any questions from the committee? Yes, Assemblywoman Taylor.
Thank you, Madam Chair. And I just want to thank you for your work on the amendment. I was concerned about the lack of the eyes from health professionals, medical professionals on this, but this bill, this amendment takes care of that for me, so I'm going to be a yes. So thank you for your work on that.
Thank you. Any other questions? Are we? Okay. Any other questions? I would entertain a motion to amend and do pass. Assemblyman Gray, a second from Assemblywoman Gorlow. Any discussion on the motion? Seeing none, all those in favor, please signify by saying aye. Aye. Any opposed, nay. The motion passes unanimously with those present. And I'll assign that floor statement to Assemblyman Gray, please. We'll move on to Assembly Bill 383.
For the record, Patrick Ashton, Research Division, LCB. Assembly Bill 383 was heard on April 10th. It establishes the Right to Contraception Act, which generally prohibits a governmental entity from enacting or implementing any limitation or requirement that singles out contraception and substantially burdens the access of a person to contraceptives, contraception, or information related to contraception, or the ability of a healthcare provider to provide contraceptives. And for the sake of time, I will go straight to the amendments. Assemblywoman Torres proposes the attached conceptual amendment. In summary, the amendment adds a definition of reproductive health services, which means medical, surgical, counseling, or referral services relating to the human reproductive system, including, without limitation, services relating to pregnancy, contraception, miscarriage, in vitro fertilization, or any procedure or care found by a competent medical professional to be appropriate based upon the wishes of a patient and in accordance with the laws of the state. Number 2 makes replacement and conforming changes throughout the bill with this new definition. Number 3 revises Section 8, requiring the director of DHHS to include in the state plan for Medicaid a requirement to reimburse services for administering and dispensing contraceptive prescription drugs or devices within the scope of practice of the healthcare provider in an outpatient setting. Number 4 deletes Section 9 through 19, which expands health insurance coverage for certain contraceptive and other health services. And additionally, Assemblywoman Torres proposes the following amendment, which is not part of the attached conceptual amendment to the work session document. Number 5, provide that the definition of reproductive health services in item 1 is not applicable to Nevada Revised Statutes 442.250. Thank you, Chair.
Thank you, Mr. Ashton. Are there any questions? Seeing none, I'd entertain a motion to amend and do pass. Thank you, Assemblywoman Gorlow, and a second from Assemblywoman Thomas. Thank you. Is there any discussion on the motion? Assemblyman Hafen.
Thank you, Madam Chair. And I have some concerns today over potentially taking away the zoning authorities from our local municipalities. I do believe that they should have control on where some of these medical facilities are located to prevent that they are not located in the middle of a residential subdivision. So I'll be voting no today. Thank you.
Any other discussion? Seeing none, all those in favor, please signify by saying aye. Aye. Any opposed, nay. Nay. Please raise your hands. Assemblyman Hafen, Assemblyman Koenig, Assemblyman Hibbets, and Assemblyman Gray are nays. The motion passes, and I would assign that to Assemblywoman Torres. All right, we will move on to Assembly Bill 403. Mr. Ashton.
For the record, Patrick Ashton, Research Division, LCB. Assembly Bill 403 was heard on April 3rd. It removes the designation as a facility for the dependent of a halfway house for persons recovering from alcohol or substance use disorders, thereby eliminating the licensing but preserving the certification requirement through DPPH DHHS. By removing the designation, halfway houses are exempt from certain duties, requirements, prohibitions, and exemptions that apply to facilities for the dependent. Finally, this bill replaces the term halfway house with recovery house and preserves certain immunity from liability for volunteers of a recovery house. And there was an amendment to revise the effective date. Thank you, Chair.
Thank you. Are there any questions? Seeing none, I'd entertain a motion to amend and do pass. Assemblywoman Gonzalez and a second from Assemblywoman Taylor. Any discussion on the motion? Seeing none, all those in favor, please signify by saying aye. Aye. Any opposed, nay. The motion passes unanimously. And I would assign that to Assemblywoman Newby, please. I'm going to talk about that now. Yeah. Okay, so we're going to roll Assembly Bill 283, which was added to the agenda, but we will have a work session on Friday and hopefully get that bill to a point where we can work session on Friday. We are going to close out the work session and move on to our hearing today. We are being graced for the first time this session by our speaker, Speaker Yeager. Welcome to the committee, your studious and hardworking committee on Health and Human Services. I will open the bill hearing on Assembly Bill 389. Please remember to state your name for the record. You may begin when you're ready.
Good afternoon, Chair Peters, members of the Health and Human Services Committee. My name is Steve Yeager. For the record, I represent Assembly District 9, and I just want to say it's a pleasure to be in this committee. It is the first time this session, and I want to thank all of you for the hard work this year, this session so far, and your staff. I don't know if I'd say fond, but I have memories of being on this committee, my first session, and wow, was I confused about what was going on when it comes to health and human services. So I appreciate the kind of issues that you have to tackle, the intricacies of healthcare, financing, and policy. And I know you've been here a lot of hours, and especially those who were in judiciary this morning. Thank you for the long day. So thank you for that, Madam Chair. And it is my pleasure to present to you this afternoon Assembly Bill 389, which provides Medicaid waiver coverage for certain services to incarcerated youths and certain adults. Before I begin, I did want to note for committee members that I did submit a conceptual amendment for the bill, which I believe is uploaded on Nellis, and I'll go over that at the end of the presentation. It's not too involved, but we'll save that for a little bit later. First, I wanted to give you a little bit of background on this bill. The purpose of the bill is to provide incarcerated individuals who are released from prison with access to health care without interruption. A major problem that we have is that individuals who are released often lose access to care or they have disruptions once they are released from incarceration. However, many in this population have significant physical and behavioral health care needs. I don't think that's a surprise for anybody in this building. We talk about it in other contexts and certainly applies to the incarcerated population. Just as an example, many of these individuals experience chronic and infectious disease, such as HIV or hepatitis C, and many suffer from severe mental health illness or substance use disorders, really at a much higher rate than our general population. Managing their health conditions and meeting their health needs is really crucial for their reintegration into our community, and frankly, it improves their chances to succeed outside the prison system, which is something we should all want. So currently, we have many adults and youths who are in the criminal justice system who do qualify for the Medicaid program, but they cannot be enrolled because there is a federal inmate exclusion policy. That policy prohibits Medicaid from paying for services provided during incarceration. There are certain exceptions, but that is the general rule. However, once they are released, they can be enrolled. In the 2021 session of the legislature, which in all candor seems like 2 decades ago at this point, it was only 2 years ago, but this very legislature passed Assembly Bill 358. That was a bill that had broad bipartisan support, and that required the Department of Health and Human Services here in Nevada to suspend rather than terminate Medicaid eligibility when a person was incarcerated. So, meaning they wouldn't have to reapply. They would just be suspended. And it also authorized incarcerated individuals to apply for Medicaid if they weren't already enrolled, up to 6 months before they were scheduled to be released. A dashboard hosted by our own Office of Analytics shows that approximately 73% of inmates released from the Department of Corrections in January of 2023, so about a year ago, 73% were enrolled in Medicaid within 30 days of their discharge. Now, that is a statistic that is going in the right direction, because before we passed the bill last session, the last time this was measured in 2020, only 42% of inmates were enrolled within 30 days. So we went from 42% to 73% in a matter of 3 years, which I think has a lot to do with Assembly Bill 358 and a lot to do with our state agencies making this a priority to get folks enrolled. So while Medicaid enrollment upon release is definitely helpful, individuals who are just released from prison often face difficulties accessing care and services during that crucial transition period between the release from prison and finding care in the community. They have a lot of other things going on when they're getting released, including going to parole and probation, trying to find housing, trying to find employment, and I think unfortunately sometimes the healthcare piece of that falls to the bottom of the list. In addition, the healthcare provider shortage in our state makes it difficult for these individuals. Once they manage to get back on Medicaid, they may not be able to access that care in a timely manner. Doctor's appointments may not be available. For instance, a recently released inmate with HIV who needs a doctor's appointment to receive prescription drugs runs the risk of not being able to get that appointment and falling off of that medication. So perhaps they have it when they're released and then they lose it. So the gap in access to health care is an additional stress and risk factor for these individuals. And frankly, I see it as a public safety issue. If we can make sure that people are receiving the health care that they need, I think generally speaking, they're going to be less of a risk to the community. So let's get to the bill, and I promise I don't have too much more to go over. I know it's been a long day. So here's the bill. The Center for Medicaid and Medicaid Services, or CMS, they've realized nationally that this is a problem, and they have offered states a cost-effective solution by providing the opportunity to apply for a waiver. And that waiver program aims to reduce or close this care gap. So Assembly Bill 389 in front of you requires Nevada Medicaid to apply for such a waiver to solve the problem of the care gap between prison release and receiving community-based care. As of February 2023, which is now 2 months ago, the CMS has approved one such waiver in the country, and 14 additional states have a pending application to be able to provide this type of service. And I will note too, I provided an exhibit on Nellis, and it has a selection of hyperlinks you can go to, because I know we can't provide all the source material, but if you're interested in any of the things I've talked about, in all the free time that you all have outside of this building, there are plenty of links here for you to read those things if you're interested. So the objective of the bill, obviously, is to allow these individuals to create their needed care network in the community prior to release. Now, if this waiver is granted, Nevada Medicaid can provide coverage of various services for both incarcerated youth and adults with certain health conditions for up to 90 days before the scheduled release. So let me tell you about what those kind of treatments are and who would be eligible for them under this waiver. The treatment would be case management, consultation with behavioral and physical health care providers, laboratory and radiology services, prescription drug coverage, including for medication-assisted treatment, which is a way that individuals who are incarcerated can try to start to get off of harmful substances like opiates, and then assistance through community health workers. So those are the services. Now, who would qualify for these services if we get the waiver? You have to be under 18 years of age. If you are pregnant or not more than 12 weeks postpartum, you would qualify. And then finally, if you were diagnosed with a behavioral health disorder, a chronic disease, including HIV, or have a developmental or intellectual disability or traumatic brain injury. So that would be the universe of folks we're talking about, and of course we're talking about people who are incarcerated as well. So that's going to really limit the numbers in terms of who might be eligible. So the conceptual amendment, briefly want to just summarize that for you. There were, I believe, 3 parts to it, and you should have that on a document that looks, can't really see this on the monitor, but it's a 1-page document. So for the first thing the amendment does is it removes the references to the state plan for Medicaid and instead requires the state to provide the coverage under the Medicaid program. That's really just cleanup language to make sure we're saying the right thing in the bill. That was a technical amendment requested by LCB staff upon guidance from Nevada and Medicaid. Staff also asked to revise existing Nevada statutes relating to such waivers that make similar references to the state plan. Second, the amendment requires the Department of Corrections to cooperate with the Department of Health and Human Services in determining who the beneficiaries might be of that program, because of course they have information about who their inmates are, what their health information may be. We want to make sure that our agencies are working well together to identify and enroll eligible inmates in a timely manner. I will say I have all the confidence in the world that our new prison director, who also was our old prison director, Director Zarenda, will do, I'm sure, a great job of coordinating, because in speaking to him, I know he knows how important it is to make sure people get health care so they don't end up back in jails and in prisons. So, in conclusion, I think what we're trying to do here is enroll high-need patients in the state Medicaid program 3 months before they're released, give them access to health services. If we do that, we can improve continuity of health care, prevent disruptions, and ultimately contribute to improved health outcomes and reintegration of former inmates into our communities. I believe this bill will contribute to greater stability in their lives, thereby reducing the risk of recidivism, meaning we're all going to be safer, and providing broader benefits for all Nevada communities. So with that, Chair Peters, members of the committee, I thank you for your time this afternoon. I urge your support of the bill, and I'm certainly happy to answer any questions. And I do believe I have backup in the room too if you have specific questions about Medicaid waivers and all of that good stuff, because when I was sitting in your seat some years ago, I had no idea what Medicaid was, and I didn't know what a Medicaid waiver was. So if you have those questions, I do have some backup. Thank you so much, Madam Chair.
Mic is not working. Oh, having delay on the mic lighting up. It's fine. Yeah, we've heard a couple of Medicaid waiver bills so far this session. It's an important and interesting topic, I think, to date. But thank you for the disclaimer on that. Are there questions from the committee? I have Assemblywoman Taylor. Please go ahead.
Thank you, Madam Chair, and thank you, Mr. Speaker. It really does seem to make sense that we give these folks as much of an opportunity as we can to be reintegrated into society. I just have this is really two clarifying questions. One is, I want to make sure I did miss it. Is this a common practice in other states?
So, Steve Yeager, for the record, there has been one state that has successfully gotten a waiver, and I believe that's California. And I think there are 14 states with waivers pending. So I would say it's cutting edge, but it's coming. So we would get in line with the rest of the 14 states, and then I think what you're going to see, by the time CMS would get to our waiver, I think you're going to see a number of states that are already online. And I believe that's because, they see the sense in this as well, right? It's extraordinarily more expensive if we're going to rely on folks to be released from custody and then have to go to emergency rooms for care. I mean, that's a bad scenario for everyone. So I think the reason you're seeing so many of these waivers is we realize it's cost effective. I mean, I'll be honest, it costs money. It's going to cost the state money to provide these services. And so should this bill pass, it's going to have us stop in the Ways and Means Committee for quite a while, I'm sure. But I think it's money that's well worth investing given what the return is and given what the alternatives are.
Thank you, Mr. Speaker. If I may ask my second clarifying, I thought, again, I may have missed this as well. I thought you said something about an interpretive dance that was a part. I must have missed it. I'm sorry. Thank you, Madam Chair.
I was ready to get up for a jig. I'm not. Could use it today. Assemblywoman Newby.
Thank you, Madam Chairwoman, and thank you, Mr. Speaker, for this bill. I particularly appreciate the portion in and around mental health services and continuation of those supports for folks getting out. My question is, and maybe you need to phone a friend, in terms of particularly maybe psychotropic medications that control mental health illness in folks that are getting out of incarceration. Are those medications filled in a way that those individuals can then use enough to then get to that bridge, whatever their next appointment is on the outside? Because what we certainly wouldn't want is for the medication to stop, for the behaviors or concerns to reoccur, and for them to end up potentially right back.
Steve Yeager, for the record. I don't think I have any friends here from the Department of Corrections, but I'm just making sure.
We've got a few in the back. Please come on up. Make
I would
yourself
like
comfortable.
to correct the record. They were directly behind me. So Steve Yeager, for the record. And yeah, I'm going to pass that question on. And I will say before I get there, I know that's a concern that we've had in this building, gosh, a long time, right, is what happens when someone's on medication. The last thing you want to do is release them and say, good luck, especially if it's a medication that's stabilized a serious mental illness. So I do believe NDOC is addressing that need. So thank you for being here. And now you're in the hot seat.
For the record, Harold Wickham, Deputy Director for the Department of Corrections. It's Wicham. And through the Honorable Chair to the distinguished Assemblywoman.
Please feel free to go directly to the member.
Thank you. Currently, the Department of Corrections provides a 30-day supply of medication upon release.
And, I think if I could add, Madam Chair, I think one of the intents of this bill, too, is 30 days is great, right? But we have provider shortages, and we have some difficulties there. So my hope is by bringing the Medicaid coverage in, that is part of that release plan. It's not necessarily just you're going to get a 30-day supply of medication, but we're going to help you find a provider in the community who is a Medicaid provider so that you've got an appointment set up so you don't get to the point where you've run your 30 days. And especially if it's something for severe mental illness, the likelihood of you ending up back in a hospital or in jail if you stop taking that medication is quite high. So I think that's the piece that I hope will help, is that I don't like the phrase warm handoff necessarily. Everyone uses that phrase, but there is a handoff somewhere there. So thank you.
Thank you for the question. Assemblyman Gray.
Thank you, Madam Chair. And let me preface this with, I'm tired and I'm not reading legalese so well, and, you may have covered this, but is the intent for just people under the age of 18? Because I'm reading in Section 2, Section 1, Subsection 2, a person is eligible for the coverage described in Subsection 1 if the person would otherwise be eligible for Medicaid if he or she were not incarcerated and is under 18 years of age. Should there be an or after that age, or Is there something missing here?
Steve Yeager for the record, and I'm sorry, Madam Chair, I usually go through the chair and I forgot to do that. So let me do it one time. Through
Okay.
you, Chair Peters, to Assemblyman Gray.
Please feel free to go directly to the member.
Thank you. See, Mr. Wickham knows how it's done in the building. I am still learning, but you're not that tired because you found something good in the bill. So, I mean, I would defer to legal whether we need an or, but I think the intent there is to capture, it is, I think it should be read as an or. You're either under 18 years of age or you've been diagnosed with one of those illnesses, and then there's another or, but Madam Chair, if legal would like to weigh in, I don't know if we need to correct that or if it's, if it would be read that way.
That is a good question. Mr. Robbins.
Eric Robbins, LCB Legal, for the record. I do not think that any correction is needed because it says that a person is eligible for the coverage if the person would otherwise be eligible if they were not in jail, and then either they are under 18, they have been diagnosed with any of these conditions, or they're pregnant or not more than 12 weeks postpartum. So that or that you're looking for is in 2B there, or 2B after number 7. So that the or there makes it clear that it's A, B, or C.
Madam Chair, Steve Yeager for the record, and this could be an Oxford comma situation, and I've had too many Twitter battles about that so far. So we'll just say, I think that with that legal explanation, it is clear on the record what the intent is, and if some judge is reading this sometime in the future, let that be a very clear statement that is to be read to be or. But I think the question was a good one, Assemblyman Gray, and it shows me that you're reading the bills. Thank you.
Thank you. Sometimes these lists, it's like Inception, right? It's the list within the list within the list. Are there, I have Assemblyman Wynn. Are there other questions that I should put on my list before we? All right, Assemblyman Wynn.
Thank you, Chair. This is not the first time that that was done today, so no worries. Not only this committee, so we all had a rough day. Thank you, Chair. Again, thank you, Speaker, for this. I keep thinking on like ways to really see and walk through this bill inside my head and how it comes out. And you may have said it, and again, apologies, not enough caffeine today. In terms of the case management piece, will then the individual will be somehow first in line or have some sort of continuous Medicaid coverage when he or she is being released because they are qualified for this treatment, they are enrolled in this special program. Once they're released, will they have preference or priority in line in terms of that continuous Medicaid enrollment, or they have to kind of go through case management and start over again?
Steve Yeager for the record. I will try to answer that, and if I get something wrong, I'll ask my friends from the Department of Corrections to come up and back me up. But, you know, I think the intent is, assuming we get the waiver from CMS, because we have to do that, and before we get the waiver, we have to apply, which is what the bill is requiring. The difference is that they will be eligible like 90 days before release, meaning the state's going to start paying for those things, reimbursing the Medicaid reimbursement rate at 90 days before. So I think the difference now is like you don't get it until you walk out the front door. So I don't know if I'd say first in line, but it's just 90 days before they're going to have the ability to get all of this. Now, you know, the prisons are going to have to figure that out, right? I mean, there's not a Medicaid clinic like with inside the prison, right? So there are some logistical things that will have to be figured out there. But I think what the idea is they can start trying to set that stuff up 90 days before. So hopefully we don't end up in a situation where they're being released and don't have anywhere to go. So in that sense, we're giving everyone a 90-day head start before release. And so if it's case management or if it's all those different things that were mentioned, prescription medications, psychological appointments, I think that can start to happen sooner in the process. Of course, you still have to be eligible, right? But I don't know. Does that answer your question, or should I bring up?
No, actually, Mr. Speaker, your phone a friend folks did nod their head while you were answering. So
We welcome you to come back up and let us know And in this committee, we have not heard many of the pharmaceutical bills that have gone through this building there in Commerce and Labor, which is our partner timeframe committee. However, this continuity of providing medication has come up quite a few times, right? So this allowing for there to be the continuity of information within a specific healthcare provider being Medicaid, right, allows for that person to remain consistent on their access to it, because that data doesn't have to change hands, it doesn't have to be grabbed from one place to another place. So there's a continuity that comes with the backstop of having that 90 days. Please go ahead.
Thank you, Chair. Kirk Widmar for the record, WIDMAR. I'm the Chief of the Offender Management Division for the Nevada Department of Corrections. So currently, based on the law that was passed out of the 2021 session, we begin to engage the offender at approximately the 90-day mark and get them enrolled into Medicaid. Upon release, all those facets are in place. They're provided a Medicaid number, and it is activated upon the release into the community. So they have active Medicaid when they go into the community. Establishing providers and things like that are still some of those challenges that, of course, would be faced. But as far as all the administrative part of being prepared to be released, that is all being completed before their discharge. If I may, one of the challenges that the unintended outcomes, if you will, part of that process is they have to select an MCO related to their discharge or release. Although the law says 6 months currently, we engage at about 90 days because of the parole component. We need to understand which offenders have been granted parole to be able to go. The discharge offenders aside, we know that group, and so they go through this process. Once we understand that offenders have been granted parole, then we focus, and that generally happens at 90 days prior to their discharge date or their parole date. So we engage them and get them enrolled. Working very closely with our colleagues, thank you, at the Division of PMP, a very small group, and working with the speaker to try to figure out if we can capture how to address that group, is an MCO gets selected. Then we find that as we look at some of the more difficult offenders, the type of crime, whatever the situation is, now needs to be placed in the community, specifically speaking about those going to a halfway house. Those offenders that go to the halfway house, that halfway house may operate under a different MCO. And the challenge that sometimes we face is getting it turned over and enrolled in a timely manner where the loss of funding associated with the halfway house doesn't slip through the cracks. It's a very small group, but with the change in the law, we are going to track and absolutely be available to the speaker, to the committee, to be able to provide if this is something that we can address before work session, or if this is something that we go forward with and just see how it tracks out. But I just wanted to provide that data because I think it's a responsibility from the Department of Corrections to let the committee know of how the intended bills that they vote and pass play out in the real world. When it gets to the Department of Corrections, I just wanted you to have that information. Thank you.
Quick follow-up, Chair.
Please go ahead.
And thank you, sir, for stepping up. So I just want to make sure that it's on record, it's clear that what you're saying is that there is a warm handoff process, but there is a bit of a disconnect in a certain ways that we do things, so that we need to kind of come back and kind of fix a couple of things because you are handing off to another group, but if they're working with a different, I guess, MCO providers, then that handoff become a little bit of a stand still, and then that patient is lost somewhere in the shuffle.
Kirk Widmar for the record. Yes, that's exactly right, Assemblyman. We lock the MCO in. We try to wait to the last minute. Our embedded specialists from the Division of PMP are excellent partners to work with. They scramble. There are obviously some rules around educating and representing or sponsoring one MCO over the other that the department and the Division of PMP have to be very careful about. And so we do our best to be a very neutral education component related to here's where indicatively you may end up going, especially with certain types of crimes where there's very, very limited resources in the community. And so, yes, 99% of the time, the continuity of care, aka the warm handoff, does happen. There are only some small situations that I think are worth noting and monitoring, and if possible, correcting, that we capture the entirety of the group, because I believe that is the intent of this committee and that is Speaker Yeager.
Thank you, sir. Thank you very much for the answer. Thank you, Madam Chair.
Thank you. I think this is one of those cases where, what was it used to say, Speaker, don't let the perfect be the enemy of the good. We're taking a step forward, and it's doing a lot of good, right? Like, this proposes some really good movement forward, and then there's some infilling that has to happen, and that's often the case in the healthcare industry, right? Where we start to see, once we start digging, right, those gaps. And it's our job, I think, to ensure we're monitoring those. So I appreciate the Department of Corrections' interest in following through with that into the future, as we have to develop legislation to ensure we're capturing those. Are there other questions from the committee? Seeing none, thank you, Mr. Speaker, for the presentation and for our call of friends and your attendance today. We appreciate you being here. We are going to go ahead and move into support testimony for Assembly Bill 389. We'll start here in Carson City and then move to Las Vegas and then go to the phones. Please remember to state your name for the record. You may begin.
Good afternoon, Chair, Vice Chair, members of the committee. My name is Erica Roth, ERICAROTH, on behalf of the Washoe County Public Defender's Office, testifying in support of this bill this afternoon. Our clients are often released from the custody of NDOC with $25 and well wishes, and this is a very important step in ensuring that there is a continued continuity or warm handoff after they are released. AB 389 ensures that when individuals are released back into our communities, one of their most basic human needs are met, and that is their health care. Something that we see very often is our clients are finally diagnosed when they do enter into the criminal legal system with some mental health disorder. They are then treated and often stabilized, but if they are not set up to succeed when they are released, it is inevitable that they will end up back into the custody of law enforcement. And so the costs for this will be borne either through funding this very important program or by reincarcerating these people. And so we do urge your support and thank the Speaker for bringing this forward.
Thank you. Please go ahead.
Thank you, Madam Chair. John Pirro from the Clark County Public Defender's Office. I'd like to echo the comments of my colleague, Ms. Roth. One of the things that was talked about a little bit is there's going to be a cost up front, but I think the cost savings are going to come on the back end when we're not putting somebody back in custody. One of the biggest difficulties that we have is when somebody gets released without a good supply of their medication or a good plan of where to continue to get medication. What we see is that person destabilizes and then winds up back in the criminal justice system, and then people like my friend Mr. Inglesby has to deal with that, as well as the police, and we don't want that to occur. So our goal is always to see when a client is released finally from the time that they're doing that, we hope to never see them again in that capacity. This bill goes a long way towards accomplishing that, and we'd like to thank the Speaker for bringing it forward.
Thank you. Please go ahead.
Good afternoon, Madam Chair, committee members. Todd Inglesby, President of Professional Firefighters Nevada. This is a great bill. We see these folks and run on these folks all the time. And a lot of the remarks that they talked about of, hey, they just got out of jail, we're trying to get on their feet. Some of them don't have IDs to even go get prescription medication. So this would be a great start in the right direction, and we support this bill wholeheartedly. Thank you.
Good day, Barry Cole, B-A-R-O-I-C-O-L-E. I love this bill. In fact, I feel like Moses before Pharaoh saying, let my people go. Every single category, I treat these people. Yeah, don't let them fall through the cracks. Please. When I was working at State Mental Health, we took people directly in transfer from Department of Correction. We knew when they were being released, they got committed, they got sent to Northern Nevada Adult Mental Health. We provided continuity of care. We plugged them into outpatient services. With case management, this really could happen during the 90 days prior to release, so they're ready to go and they don't have to pass through another inpatient situation, but could go direct to outpatient providers. I see nothing but good in this bill. I ask you to consider it. Thanks.
Thank you. Seeing no one else coming up to the desk in Carson City, in Las Vegas, is there anyone who'd like to provide support testimony on Assembly Bill 389? Seeing none, BPS, is there anyone on the public line to provide support testimony on Assembly Bill 389?
To testify in support of Assembly Bill 389, please press star 9 now to take your place in the queue.
Thank you, Chair Peters and committee, and thank you, Speaker Yeager, for bringing this bill forward. My name is Dayla Gibson, Daela Gibson, Director of Public Affairs for Planned Parenthood Marmonte. We support this bill and ditto other statements made in support of this bill. Thank you.
Thank you. BPS, are there other callers on the line?
Chair, there are no other callers to testify at this time.
All right, we'll move into opposition. Is there anyone in opposition of Assembly Bill 389 in Carson City or Las Vegas? Seeing none, BPS, could you check the lines for opposition testimony on Assembly Bill 389?
Chair, there are no callers to testify at this time.
Thank you. Are there folks in neutral on Assembly Bill 389 here in Carson City or Las Vegas? Seeing none, BPS, would you check the lines for neutral testimony on Assembly Bill 389?
Chair, there are no callers to testify in neutral at this time.
Thank you so much. I would like to invite the speaker back up for closing remarks, if you would.
Steve Yeager for the record. Thank you, Madam Chair and committee members. And I think we saw an example of what I mentioned earlier is, the healthcare system is complicated. You pull a thread here and something moves over in the other direction. But I think that provides us with opportunities to address those challenges. So I certainly appreciate the concern that was brought up by the Department of Corrections, one that I was unaware of, but one I think we can probably solve. So certainly as this bill moves forward, if there's an opportunity to solve that problem, this session in the context of this bill would certainly love any input from our friends at NDOC about how we can make life easier for them and the offenders getting out. And just want to thank Mr. Cole as well. Mr. Cole used to be my constituent when he lived down in Las Vegas, and I was very sad to lose him, and I told him if I lost by one vote, I would blame him forever, but thankfully that did not happen. But I thank him for his enthusiasm, and just thank this committee again for the work that you're doing. Healthcare is really, really complicated in this country, way more complicated probably than it has to be, but that's a result of decisions made before we were here, but now that we're here, it's on us to fix these challenges, and I think this bill is not going to solve all those challenges, but it will make a big difference in the lives of a lot of people getting out of incarceration and hopefully get them on the right track, which in the end really not only helps them and their families, but helps all of us and makes Nevada a better place to live. So thanks for your consideration, Madam Chair, and thank you, committee members.
Thank you, Speaker. And we will go ahead and close the hearing on Assembly Bill 389. And with your permission that I did ask for previously, I would like to entertain a motion through work session to work session this bill immediately. So I will open work session for Assembly Bill 389 and would entertain a motion to amend and do pass. I have a couple of motions. I'm going to give that one to Assemblywoman Gonzalez and a second to Assemblywoman Taylor. Is there any discussion on the motion? Assemblyman Gray.
It's that tired thing again, sorry. I'll vote to get it out of committee, but there's still things I want to see worked out. It's good policy, but on the other end, there's always fiscal too, so.
Thank you. Any other discussion? Seeing none, all those in favor, please signify by saying aye. Aye. Any opposed, nay? The motion passes unanimously with those present. Thank you, Mr. Speaker. I would take that floor statement. Yeah. All right, we'll close the work session. We close the hearing. Our last agenda item today is public comment. We will start in our physical locations and move to the phones. For public comment, please state your name before you speak. We will start a 2-minute timer for those who would like to provide testimony, or sorry, public comment today. If you are on the phone lines, we do ask that you spell your name for the record. Seeing nobody here in Carson and come up to the desk for public comment, and no one in Las Vegas, I would ask BPS to check the line for those who may like to provide public comment today.
Chair, the public line is open and working, but there are no callers at this time.
Thank you for that. With that, we will close out public comment agenda item, and I just want to let the committee know that we have a call of the chair agenda item on Friday, a potential work session, so please just beware, have your attaches check the schedule and your emails as we potentially call that meeting on Friday. And with that, we are adjourned.